Okay, Dr. Brittany Schamerhorn, I'm really looking forward to this conversation today because as I think through episodes, I'm always trying to think about what do I always want to send home with people? And this is like a really important and important, let's say, topic that's close to my heart right now, because my God, this is such a hard transition to go through, not only as a care provider for people, but like myself. And so I can't wait to hear some of your answers to some of my questions and just, help us better understand. So thanks for being here today.
I'm excited to be here. Thanks for having me.
And so the transition to menopause, like this is I've covered this topic in different ways before, but every care provider has a different skill set and toolbox. And I think people have a really hard time knowing, like, who do I get help with? Like, do I read things? Do I listen to things? Do I go see someone? And I quite often find they say, well, first of all, you have to know yourself. And I kind of explain to people, I'm someone that likes to do a little bit of research and understand things. So when I show up to an appointment, I feel a little prepared for what they're going to say and what offerings they'll give me. Whereas other people are like, nope, that's not me. I want to go see an expert right away. And so I try to meet people where they're at. And a lot of times, let's say people right now are some people will be starting with their GP, for example, trying to get advice. Other people are saying, like, nope, I have a different preference. I'd like to start with a naturopath. I want to know what they have to offer. And so I really look forward to you explaining kind of like your take on how you would help people through this transition. And we were talking a little bit before we hit record. I feel like people are coming in on two different ends of a spectrum right now. Some people are kind of really, educating themselves and maybe feeling overwhelmed, but I don't know what to do. I've heard of all this and I'm just like juggling all these ideas. Whereas I'll be honest, I feel like a lot of my friends, for example, I want to commiserate with them a little bit. Like, are you guys like feeling this? And I just want to like feel like I'm not alone. And then they're like, no, change the subject. Like, I'm not, no, like that's for old people. And so I find people deal with this so differently. And so let's get started by you introducing yourself to people listening.
Okay, well, I'm Dr. Brittany Schamerhorn. I'm a naturopathic doctor in Kelowna now, just recently relocated. And so my main practice, I want to say in the past 5 years, 4 years, has been solely, specifically 4 years, 3 to 4 years, has been like midlife care with this transition of like perimenopause, menopause support. And like you said, what it means is there's such a drive for knowledge and women just want to understand what's happening. And I think often in this time period, women are at their peak of their lives. They're busy with their career and their family, and they just want answers to what's going on. And so my patients wanting those answers have driven me to want to be in this space.
So you felt like it was more like a need for, everyone having these questions. And wouldn't you say too, like this information's exploding lately. Sometimes it's almost like hard to keep up with it, I find.
Mhm.
It's super interesting, but I find myself listening or like reading books or listening to different podcasts and kind of thinking like this is 2024. Like this seems like pretty basic stuff given that half the population goes through perimenopause and menopause. Like why are we learning some of these basics now?
It's insane. Well, if you think about like so many times all patients come in and they've never thought about their menstrual cycle until they want to get pregnant.
Yeah.
And so you don't think sorry, you don't think about what your menstrual cycle might do for you or what you'll miss from it from the hormones until that starts to go down. Because when we look at our education from it, it's in school. And literally the only education was how to not get pregnant. We didn't explain the hormones around getting pregnant, that it's only a week of the month, like any of that. So there's no base knowledge. And unless someone's mom is going to give them, like mom or dad, whoever in their family is going to give them that education, they then go into adulthood and they don't learn about it. I want to say probably like 80% of my patients have no idea about ovulating until they try to get pregnant.
Hmm.
Until they're like, oh, wait, do I like I just pee on this like pregnancy, like LH strip? Like, what is this? And then
Hmm.
after that, they get pregnant, have a kid
Hmm.
postpartum, and then we just like live in this naive chaos, I guess I'll call it, until things start to change. And for so long, we've dismissed it as other things, which are valid because they
Hmm.
can happen, such as stress or other health concerns. But then menopause was only the loss of your period. Like it was, I feel like we really ignored this perimenopause phase. And it was like postpartum, momhood, life, no period, that's it.
Mhm.
And so menopause only happened after that. And we just was like, this is no, like you're fine. Like this is just in your head. This is what everyone does. And I think the conversation is really good because, like you kind of said originally, it's validating for a lot of women to be like,
Mhm.
oh, I'm not the only one, or there's also options. Like it doesn't have to be this way. Because I think we're moving away from hiding our symptoms and hiding how we're feeling to actually just owning it and being like, I could feel better and I deserve to feel better.
Yeah, I think of a couple things when you say that. Like, I think we've always thought before about menopause as like our drying up time or like, it's like the end type of thing. And so I feel like the generations older than us are a little bit like we don't talk about that because it's almost like, yeah, it's this fear of aging. There's this I'm not a sexual being anymore type of thing kind of tied up into all of that. So that's one thing that makes me think about that. It's like we don't want to admit that we're different. But then
Mhm.
also too, I think of like when the fact that this is such a let's say new topic that's gaining so much momentum. I think anything new comes with skepticism
Mhm.
because it's like when COVID came, we're like, what? No, what? This is not a virus that's going to affect the world. Like, are you serious? But same with, I feel like all of this information, like as you're consuming it, you're like, are these people just raving about something they're trying to sell? Because I've never heard this before. I think that that's another thing that people are getting hung up on is like, why are we just talking about this now? It has been around forever. But I always say, like in healthcare, we're always learning. And for some reason, this is something that we just haven't spent enough time learning about. And you hear over and over and over again there hasn't been enough research done on women and that sometimes we're harder to study because we're not so regular, right? Like we have those transitioning cycles and changes throughout the month that perhaps it's a little bit harder sometimes to collect data, right? To
Yeah.
standardize things.
Yeah. And I think I'll kind of always frame it as well, there's 2 points here. One that made me think about is when you're talking about menopause and how it used to be, it's also how we live our lives now is so different. So
Mm,
like the average age of menopause is 50 to 51, 52, depending on like what stat you're looking at. And that we have a significant lifespan after that. And not only that, but like good quality years.
mm-hmm,
Whereas before, when our life expectancy was shorter, you would like hit menopause, but you're already quote unquote old. Like you're not active, you're not traveling, you're not doing things like your average life expectancy might have passed in like the next 10 years. So, not that it didn't matter, but it wasn't as significant as a
mm-hmm,
thing because now women are still working
mm-hmm,
in when they're 50. Like, this is
mm-hmm,
when they're hitting their peak. They have to function, right? And like maybe now their kids are out and so they want to have they're traveling and doing whatever. And so it's what we expect and what we want from those years. So I think that's also a driving force is that we know we can live for like another 30 years and we
mm-hmm,
want to have good years. And to come back to like, I'll always say that menopause is this annoying, beautiful opportunity, and like perimenopause included, where it gives us an opportunity to look at and be like, what can I do for myself? What can
mm-hmm,
I do for these next 30, 40 years so they can be the best years of my life?
mm-hmm,
Because we're done with the chaos of our 20s. Like we've learned from our young adulthood, like what can we do now? And
yeah,
so it's this opportunity where you actually get to, and it's the symptoms and the annoyance of it is what brings you into a healthcare provider, but you can use that as a chance to actually make the next 40 years your best.
mm-hmm. I think it'd be helpful just to kind of like help people identify. So when someone comes to see me as a physio, a pelvic health physio, I would say that the symptoms that maybe bring them in, and I'm just going to generalize kind of between the ages of like 40 and 60, would be, they're coming in with, let's say, more stress incontinence, like I leak when I cough, sneeze, laugh. I have to go to the bathroom all the time. I'm getting up a lot at night. My bladder's like ruling my life. It hurts to have sex all of a sudden. I'm having some pain in my pelvis. Like those would be the things that associate them with someone like myself and would bring them in. But I'm always like asking other questions. I'm scanning for like, their bowel health, their stress levels, like different things that show me how their nervous system is kind of coping, let's say. And I always ask more questions or anything else changing at this stage. And so, will you go through let's say some of the hallmark signs and symptoms, besides the ones I just listed that are more related to the pelvis, that people might come to you, or typical signs and symptoms that might make you start thinking that there's like a transition phase here. So let's start with kind of like the hallmark signs and symptoms that people might start experiencing, and then let's talk a little bit more about why those changes happen after that. So because I first want people to be able to listen and be like, oh my god, I want to keep listening because I think this appeals or applies to me.
Yeah. I think there's two spectrums there where, and I look at like the patients in the early peri and then the ones who are coming in that late peri. So the late perimenopause, like menopause, early, those patients are the ones who have, say, like more of the obvious symptoms. And so they're like, oh, there's actually now options for my hot flashes or like my sleep or my vaginal dryness. And those are like the more obvious ones coming in. And I think to go all the way back to what you were saying originally, they're seeing the information and knowing that now there are options out
Mm-hmm.
there. There's that group that's coming in. The other group is, and I want to say one of the biggest is like, I just don't feel like myself.
Mm-hmm.
Like that's the line that I'll hear is like something is different and I'm not feeling like myself. I'm either more emotional, I'm not, my energy's not where it needs to be. I'm not performing, whether like at home or at work, how I want to. Like that is the biggest. And then they'll see changes in their sleep.
Mm-hmm.
And it can be subtle. So it'll be sometimes it's only the week before their cycle that they'll start to have issues with their sleep, mood, and like inconsistent. It's like inconsistent. I want to say like unremarkable symptoms where it's like you could ignore it. So like they're quote
Mm-hmm.
unquote fine, right? So they go to their doctor, they get their lab work done, everything's like fine,
Mm-hmm.
but they aren't fine.
Mm-hmm.
That's kind of one of the biggest parts. And there's like perimenopause doesn't happen in a vacuum, right? So
Mm-hmm.
there's so many other aspects that can be contributing to there. And usually it is a compound factor of all of it. But those are the people who are coming in where they like just feel lost and by the system and they just, no one knows how to help them.
Mm-hmm.
And it's not like their doctor's fault. Their doctor has their best interest in mind. It's the system doesn't have the time or the capacity, or that's like not the system's role.
Mm-hmm.
It's to help them get there.
Well, and don't you think a lot of people also, like we talked about, it's not easy to say, oh, this is menopause or perimenopause, because people are like, well, I also have like kids and they are stressful and I'm working and my parents are aging. Like, so I think that's the hardest part, is that people are like, why do you call that perimenopause? Like, that's life. Isn't that normal? You always hear people say. So I think that's what can make it so hard. And I can completely relate, because I would say those are my biggest symptoms, are just like, I just don't feel like, I often use the description that I'm the type of person that usually when I walk outside, I'm like, look at the beautiful clouds. I'm so thankful to be here. The smell of the trees is beautiful. And I would describe that I started feeling like everything felt grayer.
Mhm.
And I was like, this isn't depression. Like, people would say to me, are you depressed? I'm like, no,
Yeah.
I don't know how to describe it. Like, I'm not depressed. I just don't feel as colorful. And I'm losing my patience a bit quicker on my kids. And then, yeah, I feel terrible. And a lot of people too say, like, I keep hearing this term, like, you'll feel less confidence. I'm like, oh my God, that is me. Like, I just don't feel like normally I'm a pretty confident person, but I start feeling like I kind of want to like shy away from things. And like, it's just, I would absolutely describe, I'm just not myself. Yeah.
Yeah. And I think we have to trust, like as clinicians and practitioners, we have to trust the women in front of us.
Mm-hmm.
Like I'll have a woman, like just like you said, they're like, I know it's not emotional. Like I
Mm-hmm.
know it's not mental emotional. And especially if they've had a history of, say, like postpartum depression or something, they'll be like, I know it's not that. Like it sounds like that, but I know it's not that. And we have to trust that. And like
Mm-hmm.
we obviously like still do the due diligence, make sure we're safe, all of that. And like maybe an SSRI or an antidepressant is offered, but like we have to trust the woman in front of us, and that if they think there's something else, we need to look deeper. And
Mm-hmm.
because that antidepressant, if that's given or if that's the only option, one, now they don't feel like they understand themselves anymore
Mm-hmm.
because they've been given something that they're like, well, maybe it was depression, but I didn't think I
Mm-hmm.
was.
Mm-hmm.
And they're probably going to feel better, but that wasn't what they really needed.
Mm-hmm. It's kind of going like, it's not fixing the upstream problem, right? Like,
Mhm,
doesn't mean it's not going to help, but it may be not the upstream problem.
mhm. And it doesn't mean that it's not indicated. Like in
No,
some
no.
situations, it's literally life saving for them and it helps us do all the other things.
Mm-hmm.
but it's the woman needs to understand and feel heard that,
Hmm.
okay, like I know that this probably isn't just like a straightforward depression, but maybe an SSRI is their best option right now because it'll allow you to do X, Y, and Z as well, which is
Hmm.
now going to also work on like the hormone standpoint. It's
Hmm.
going to help like improve your sleep.
And just to
And
clarify, Brittany, sorry, SSRI, you mean for people an antidepressant, correct?
yes, sorry,
Okay,
yeah.
that's okay.
Yeah. Yeah, like I just think that it's feeling heard is the biggest thing
Oh,
because they're if they can understand, and a lot of women think, to go back to what you're asking about, oh, like it's not perimenopause, but we're sold perimenopause as hot flashes.
hmm.
And that's kind of it for a lot of people. And so if we can understand the complexity of what this transition entails, it might allow more women to feel like welcome to come in for care.
And I think that kind of like leads perfectly to what I want to ask you next, because I think that like what I find so validating when I listen to information is like what's actually changing. Because I think that like once you understand what's actually changing inside your body and inside your brain, I find that always helps me be like, okay, I'm not crazy. Like there's a reason for this. And so first of all, like if we clarify that menopause is like one day where you're 12 months after your last period. So basically, like I think we've always thought like menopause is a really long time, but technically, as of right now, the definition means one day.
Mhm.
Everything after that is like postmenopause. And then the
Mhm.
time before that is perimenopause. And I've heard, correct me if I'm wrong, this stage will last around 7 to 10 years for women.
Mhm.
And the
Yeah.
average age of menopause is around 51, 52. Is that
Yeah.
correct?
Yeah.
So then can you talk about, obviously like, you mentioned that our menstrual cycle is something we don't normally think about. Without spending like a ton of detail, can you talk a little bit about like what, because everything changes in puberty. That's the first time we get so much change. And then and then from what I understand, we most often like level off to a pretty normal cycle where we're getting certain hormones ebbing and flowing pretty cyclically. And then that starts to change. So can you explain that to people? Because I always find this helps me be like, oh my God, this is why things change.
Yeah. There's a beautiful picture that I will often refer to, and maybe I can send it to you so you can throw it into the show notes for people.
Please.
And it will basically what it shows is it'll be like pre-puberty, and then there's like a little short bit of chaos for a couple years where that's like puberty, and then exactly like you said, everything flows really nicely, and you have these like regular rhythmic cycles. And so what happens, the goal of your cycle is to get you pregnant, whether or not you want to. Your body's goal is to get you pregnant. And so in order to get pregnant, we have to ovulate and we have progesterone rise. And so what you'll see in this diagram is that there's these like regular occurrences that are pretty equal of progesterone coming up. And so every month your progesterone rises in the attempt to get pregnant, and you don't get pregnant. So we shed the lining and we move on and try again. What happens is as we get closer to, and this would be considered the start of peri, and when we compare in this diagram, you can see because there's like chaos on both ends, but the chaos in perimenopause is significantly longer. So I'll call it perimenopause is the reverse puberty, but extended. And I think when patients will hear that, they think about either their kids or like their puberty, and they're
Mhm.
like, oh, like this makes sense.
Mhm.
Um, and the first thing that will actually happen is your progesterone that you was like a really strong ovulation every month, that level starts to decrease. And this is also why fertility starts to decrease with age, because the like strength of our ovulation and the amount of progesterone that we produce goes down. And then after that, we start to spread out, like we don't ovulate as easily. So the brain is sending LH and FSH to your ovaries, being like, hey, let's ovulate, let's release an egg, let's do this. And the reason we'll test FSH to like, let's say if you've had like a hysterectomy or an IUD or whatever, and you don't have a period, is because we're looking at this signal from your brain to your ovaries to say like, how loud does it need to speak? And so the larger the number, the louder the brain needs to tell your ovaries to ovulate. And as we transition later into that, like closer to that final menstrual date, it we ovulate less and less because when you ovulate, then you will have a period. And then estrogen is sort of just like along for the ride, and its job is to thicken the uterine lining, like its job in fertility. And so the first thing that will happen in perimenopause in early peri, your progesterone drops, but your estrogen will seem higher. And your estrogen might actually be the same level, but because your progesterone is not as strong as it was before, your estrogen is stronger. And so you'll have maybe heavier periods, stronger PMS, anything like that. And then as you get closer to menopause, both of them are dropping. And so it's not until your estrogen starts to drop that we get some of these hallmark menopausal symptoms, like the hot flashes. The progesterone one is those changes are the ones that are a lot more subtle. But it's that drop, both of them drop near the end, and then eventually postmenopause, we get this like little flat line.
So because I know like we have our set number of eggs like when we're born basically, right? And so it's that ovulation though, like we start ovulating less, correct? Like there's not we won't will we start having some cycles where we don't ovulate?
Yeah, so it's like harder for us to ovulate,
Yes.
right? Or either we like that ovaries don't, or we run out of eggs, whatever it is, but it's harder for us to ovulate. Now, to make it like you can bleed without ovulating, right? There's non-ovulatory bleeds. So sometimes this will be, and we'll see this in PCOS, but we also see this in like late peri, where the estrogen has been allowed to like run rampant and it's thickening the uterus. And eventually the lining of the uterus just becomes unstable and it starts to slough off. And so that would be a non-ovulatory bleed. And so sometimes what can happen, we can get a non-ovulatory bleed close to an ovulatory bleed. And that's when a woman will be like, I just had my period. Like, why am I bleeding again 2 weeks later?
Mm-hmm.
And then we can also get something called loop cycles, which is where basically because the signals from the brain are so strong and it's really trying to ovulate, we actually will almost ovulate, like we release more than we need to.
Mm-hmm.
And so that's when we'll again have like two periods really close together.
So yeah, so basically it's just not like it's not so normally cyclical. It's just kind of starting to be like when I see the graphs, it looks like instead of this nice wave up and down, basically kind of like a quick, I've heard it before called almost like an ECG reading or an EKG reading that you can see like you're looking for this nice like certain rhythm, but that starts to get kind of like really
And
like
it's not
steeper and
even like
sharper.
rhythmically downwards. Like you'll be like, oh, you're
Yeah.
going down, then all of a sudden it's like scar, like,
Yeah.
and this is why every month can feel different because the levels of hormones, once you like, especially once we're in this like very confidently in perimenopause, we have no idea what's going to happen every month. And
Mm-hmm.
I think that also like practitioners need to be very clear with their patients about that because what is happening is normal, just like puberty is normal, right? Like we know that it's going to take some time for that to like the young girl to have some regular cycles. The reverse, it's going to take time for you to actually stop.
Mm-hmm.
What is happening is normal and to be expected in this like irregularity and different cycles every month, but that doesn't mean there aren't things we can do when you don't have options.
Mm-hmm.
But I think knowing that that is okay sometimes because people are like, but I need to have a period every month, but I need to. I'm like, but you're like 49.
Mm-hmm.
Like we have options to make it happen. Like we have so many treatment options at our disposal. And so if regularity is important too, sure. But that is also what's going to happen, but we can make the transition easier.
So can you explain to people, what because it's not easy, like you said, it's not easy to say like you are exactly doing this right now or are you exactly doing this right now, but can you talk a little bit about what those key hormones are responsible for? Because I think sometimes that's helpful for people to listen to and think like, oh my gosh, like if my progesterone's low, like that makes sense that I have some of these symptoms, or if my estrogen is doing different things, that makes sense. And also like please talk about testosterone because I know that's another one that's getting a lot more mention now. So can you just lay out for people like, you know, in their symptom profile, what makes you think of different hormones?
Yeah. So I think like one thing that you said when you're talking about yourself, like that lack of color or just like
Hmm.
vibrancy, if we think about around ovulation, that is where, like, again, our goal is to get pregnant. So we like feel our best. We're super confident. We're like attracting, like, I'm thinking like way old back, right? We're attracting the males so we can have all the babies.
Hmm.
You feel good, right? You
Hmm.
like rock the
Hmm.
conference room, like you're good.
Hmm.
And so it's that it can be very non-specific when you're saying like I just like my confidence isn't there. And
Hmm.
that's because the hormones might not be at the same level. The other thing that can happen. And that's all of them, right? So it's like both the estrogen and the progesterone, like, because it's the lead up, right? It's that lead up of our estrogen coming up.
Mhm.
And sometimes it can be the balance of the two of the progesterone as well. So progesterone can be very helpful for like sleep. It's an anti-anxiety. So if
Mhm.
like the anxiety is a little bit higher, where I find a lot of the symptoms come from, especially like mental emotionally, it's from the inconsistency of symptom, like the
Mhm.
inconsistency and the variability of all the hormones because you're so used to your regular trend.
And
Now,
sorry to interrupt, Brittany, really sorry, really quickly. I think it's important for people to listen to this that like we have hormone receptors everywhere in our body. Like we everywhere in our body, like I think we're kind of mostly talking about the brain right now, but like everywhere in our body, like our the receptors are looking for these hormones. And so that's
mhm.
why we're going to have different symptoms in like the vulva or vagina versus the brain. And so I always think about that. I'm like, well, if my brain wants those hormones and is not getting them, of course it's going to not thrive off this chaos. So sorry to
Yeah.
interrupt, but I was like, I think people are going to be like, what? Why does that affect certain
Well,
areas
and
like
that's what I
that?
was like, that's perfect transition because I was
Yeah.
going to say, like, that's mental emotionally, right? Like, there's those huge ones, and those are the very non-specific ones. I think social media and conventionally, it's really easy to hear the physical symptoms. So, like,
Mm.
if one thing that'll help me in if we're like transitioning to the perimenopause is that estrogen might be that estrogen progesterone relationship. The estrogen's a bit higher, the periods are heavier because the lining is thickening, so we might see more clots or the bleeding is heavier. We can also, like, the PMS can be worse, like breath tenderness, anything like
Hmm.
that. And then on the testosterone standpoint, it's where, well, the muscle mass change is so
Hmm.
where it's they'll be like, I'm losing muscle mass, or the weight distribution, or it's harder for me to lose weight or maintain my weight. And that's both estrogen and testosterone are involved in there. And so it can be really hard to be like, oh, it's this. And so
Totally.
I personally get really frustrated when you'll see these things being like, oh, you're like low progesterone, and they list all these symptoms. And I'm like, but it's the relationship of all
Hmm.
three.
Hmm.
And that's what's changing. It, it's so, like you said, there's hormone receptors everywhere where we could literally blame every symptom. Like joint pain is a huge
Mm.
perimenopause symptom that often gets ignored. And people will be like, oh, I have this new onset arthritis. And then we talk more in their intake, and it's like, oh, no. And then we give them estrogen, and like 2 weeks later, and they're totally fine.
Well, can I tell you, Brittany, like from a physio point of view, I think that a lot of physios would say this age of women are like the hardest to get over some of their tendon injuries and their joint. Like,
Mhm.
what am I supposed to do with this woman? Like, well, it's going to be hard because she's at a point in life. And I think that, like, again, I can't wait to share this episode with some of those physios that treat women, which is everybody, to kind of say, like, maybe you need to see if they're taking any hormone therapy. So yes, anyways, go ahead.
Yeah, I just, it's like, it's everything. It's just like crazy. Like
Yes.
it's called the burning mouth syndrome of menopause, where like the tongue is tingly and it can feel like a metallic taste in your mouth.
Yes.
Estrogen. Like I think you could probably find a symptom in every point of your body. Frozen shoulder, very
Yes.
common in the
Yes.
perimenopause transition from the hormone changes. And like you touched on earlier, half of this, we have no idea why. We
Yes.
just know it happens, and
Yeah.
we just know that we have options, but usually they're put into the same treatment. And like you said, so if they come in and they rolled their ankle, they're given the same treatment plan as a 20-year-old who's rolled their ankle.
Mm-hmm.
But those are two very different human beings.
And again, like I can't, and I want to talk about this a little bit more as we keep going, but I think it's just like to me, I listen to this and I'm like, I feel so much better when I can like see that graph and understand what's going on. Because like yesterday, I was going to pick up the kids. I've been getting lots of heart palpitations lately. Like that is not normal for me. And I can feel it makes me feel anxious. I'm not an anxious person, but I'm
Mhm.
having those. And I think most people are like, what's going on? I feel crazy. I literally feel crazy. But I feel like listening to this makes me be like, I'm not crazy. Like, no wonder I feel all this stuff. Like, to me, I
I
think
don't
that's
know
why
if
it's so important to understand.
yeah, did you hear so like I think it was Oprah Winfrey. I think maybe we talked about this before. And so her only sign of perimenopause, menopause was palpitations. And so hot
Mhm.
flashes can those vasomotor symptoms for many women can manifest as palpitations.
Mm.
And if you aren't aware of that, or like your healthcare provider is not aware of that, you come in with palpitations and you get sent down the cardiac route. And
Yes.
then everything's
Hmm.
fine. Great. Awesome.
Hmm.
Everything's fine. We're not having heart. That is great. But
Hmm.
you still have palpitations. And
Yeah.
then those are triggering anxiety, which is like now your cortisol spiking. Now you're not sleeping.
Hmm.
Like all just because it was like it was really a vasomotor response.
Mm-hmm. Totally. So, and then I think some of the other big ones for, can you talk a little bit about libido in this? Because everybody wants to talk about that as well. Like I know it's going to be another thing that you're like, it's the dance between all of the hormones, but I just want it to be another thing. A lot of women will honestly come in saying like, I can't have intercourse. But then when I ask them more about it, one thing might be discomfort. And so obviously I'm asking them about like vulvovaginal estrogen. But sometimes they're like, I just don't want to. Like I do it because I think I have to. But can you talk a little bit about that? Because I think like we deserve to want to as well.
Yes, and I think I'm so glad you asked this. I love this conversation in clinic. There's something called the sexual response cycle, which I'm sure you have touched on or know about. We as a society think that the sexual response cycle should be this linear thing where there's the arousal, an initiation, an orgasm, and then completion, when really it's this cyclical response. And we can have I'm butchering it a little bit at the moment, but where the initiation can actually come from two reasons. Drive often will come after initiation. And the initiation or the desire to want to do it can be both positive and negative depending on your situation. So let's say you're in like an abusive relationship and this is the only way your spouse stays calm, that's a negative initiation. But then you can also have the positive where like this brings you closer, you enjoy it. And for some women, I'll actually say that like having sex can be like going to the gym.
Hmm.
You don't want to do it, but you're going to feel good after. Like
Hmm.
no one wants to wake up at 5 o'clock and go to the gym. Like maybe like 1% of the population, but we do it because we know it's good for us. We know we feel better and we know we will enjoy it when we're there. And sometimes sex can be the same thing, especially if you've been with your partner for 40 years. There's not a lot exciting anymore.
Hmm.
And I think when we have this conversation and I'll show people this response and I can be like, okay, well, and I'll even ask them, I'm like, do you want to have sex? Like that alone is
Hmm.
a question. Like,
Hmm.
are you okay with it? Because if you don't even want to have sex, then that's a whole different conversation.
Hmm.
But if you want to have sex, but you're like not sure if, but like you want it to be that like exciting like it was when you were in your 20s or 30s, I think we have to just adjust our expectations and educate ourselves on what that true sexual response cycle is. There's Emily Nagoski, I'm sure
Hmm.
like
Hmm.
comes to our burnout. She talks about that there as well, which is I love her stuff. And there's another great podcast that I was listening to, and she's like, if you schedule it, like some couples, you also just need to, if it's important to you in your relationship, then literally you might have to schedule it in because you're tired at the end of the day,
Hmm.
or you do it in
Hmm.
the morning.
Hmm.
But
Hmm.
that also, I want to say that you can also have like self-satisfaction. Like it
Hmm.
doesn't, if you are a solo individual, then like you can, and if you orgasms are great.
Hmm.
So like you can also do that yourself, but you might need to just get started
Hmm.
and then you'll get into it. Outside of this is obviously like outside of all the lubrication and the pain and like you said.
Well, because I think everyone blames this on hormones, is what I'm trying to get at. Is like it's not just that you have a hormone deficiency, but like you're right, just kind of understanding how that works. Like I think we're quick to be like, I must need a hormone, and then all of a sudden I'll want to, right?
I think that's a great I'm seeing a huge with right now with the hormones because with the menopause conversation comes the hormone conversation. And I'm having women coming in and being like, I want hormones.
Mm-hmm.
And we talk and I'm like it's so interesting. My practice has transitioned a little bit even in this past year with being like, I felt like I was one of the only spaces where they were getting hormones. And now we're actually having this conversation about when it's appropriate to give it to them. And they might not need it when they think they need it. Because from like you said, patients are like either like, I'm not in perimenopause, I'm totally fine, or they're like confident that they are and they do not want to miss they're seeing everyone online and they don't want to miss this chance and they want their hormones now.
Mm-hmm.
What they don't realize is if I give you estrogen in early perimenopause, you are going to hate me. Like
Mm-hmm.
your boobs are gonna hurt, your period's gonna be awful. Like, no, no, no. That is not the time for us to do this. But like having that conversation of when to do it. But it, like you said, it's not always hormones aren't always the answer.
Mm-hmm. So then let's say, okay, so people are listening, they're starting to be like, oh my gosh, okay, there's this normal change in my cycle. There's a little more chaos leading up to, and so we've established maybe kind of in the early 40s is when this would start, roughly. Everybody's different, and there's lots of different reasons for difference. But overall, kind of starting to notice that kind of anything different we could probably attribute to some of these changes. And so that's where people are like, so what am I supposed to do about this? And I think what you're saying is like sometimes just understanding and accepting and kind of making sense of it for some people's enough, right? Like that you have to expect some chaos and things to be different, right? But would you also say like you said like we don't have to live like this, so can you just speak a little bit too? So let's say someone's listening and they're like, okay, I want to get some help for this transition time. What are my options? And obviously you're going to speak more to your profession and your scope of practice. So like what do you suggest for those people listening that are like, okay, I actually want to work with this change?
Mhm. So I think one thing to preface, um, my scope as a naturopathic doctor is very, in BC specifically, is very wide. And so in different provinces or states, depending on where the listener is at, the role of a naturopathic physician can be very different. And along with, and we touched on this briefly before, that within every profession, there's a spectrum of physicians and like clinicians in that, right? Like even in physios and pelvic physios, there's going to be a range of like what that is going to look like. Even medical doctors, right? We have the family doctors that we love, and then the family doctors that we're like, well, we're just not going to get rid of them.
Hmm.
But and that, so I just want to like quickly put
Hmm.
that out there, that so my experience is not going to be the same, or like my experience with the patient
Hmm.
won't be the same as what anyone might experience. But
Hmm.
um I have a huge scope at my disposal. And so in BC, like I can do the prescriptions, but supplements and the lifestyle is a huge part about it. And I think one thing that can be common denominator of all naturopaths is our value is time,
Hmm.
right? And so I don't think we can't forget that the huge value of working with a naturopathic doctor is we have an hour, usually, let's say like an hour initial visit. I learned so much about you in that hour. And that's what allows me to give you clarity and to have these conversations about like, okay, well, I think this is happening. And I think it's all of these confounding variables that's making it look like this. And a lot of like, no matter how an ND is regulated, even if they can't prescribe, we can still educate.
Hmm.
And so I'll have patients where they go to their doctor and they get told or prescribed XYZ, but they have no idea why. And so then we come in and we just have a conversation about that prescription or about what just happened there. And that's like, I'm just educating them on like the theory behind why we're giving them this and like why this might be beneficial. And that can be consistent everywhere. Um, I think for like women going through the transition looking for support, and I think it's huge that yes, like there is the chaos that we can expect, but you don't have to suffer through it. So there are options. And I think that really comes down to the woman as an individual. Like you said, as for you, you love to know all the things. So for you coming into my practice, it would look like, okay, great, here are some educational resources. Here's some like sources I would trust to educate you properly. We can come back, have a conversation. What do you identify? Let's try XYZ. Some women like just want to be told what to do.
Hmm.
But then also the question is, what is your capacity?
Hmm.
How much lifestyle wiggle room do we have? Right? Like, can I work on your sleep? Or is that just like not touchable right now because of whatever your life situation is? Can you afford supplements? Do we have to look at something that's going to be covered by your extended and we're looking at prescription basis? Like, this is the joy of getting to work with an ND, I think, is that our toolbox is so wide and can be so unique, but we're looking at everything, right? So can we play with your nutrition? And for some women who are super tired and they're not sleeping and like maybe their ferritin's like a 3, like that's a whole other, that's their problem really. I- I'm not going to tell them to meal prep on Sundays. Like they're
Hmm.
barely making it to soccer,
Hmm.
right? So we just have to be able to meet you where you're at, and it's what role you want to do in this, right?
Well,
Like
because
how do you go through it?
I think it's important to like ask the question now because I think where a lot of people are at, or they're like, okay, so again, like if I try to make this practical for people, that someone's come to see me and they have some of these symptoms, and then I ask them a little bit about like what's going on in your life, how are you feeling overall, where are you at with understanding perimenopause and menopause, like just give me some information. And let's say they say to me, I am like so green here, I'm just learning. okay, so I guess I need to start with getting my hormones tested. Like I think that's where everybody thinks that they need to start is like I need a baseline. I need to know what my level is and then they're going to give me a hormone that like changes my level. So please speak to that because that's just such a common thing. Like that's everybody's question. So do I need to start with my levels?
Well, and I get it.
I
Like
know.
we want to get a blood work. We want it to say like, this is wrong. You take this. This is, and so many women want their thyroid to be wrong,
Yeah.
right? Where it's like, oh, it must be my thyroid. I'll go get my thyroid tested and then I can just take Synthroid and everything will be better. Because I feel like maybe 5, 10 years ago, thyroid was the menopause, right? Like it was always the
Mhm.
thyroid out there.
Mhm.
And so, but this is like for a lot of women, they go get their levels tested, general blood work, and it's fine, right?
Mhm.
So when we're talking specifically about hormones, what we have to ask is, what do you want from that? And really, we use hormone testing mainly just one if we're looking at fertility. So most people in their late 40s, mid 40s don't want to get pregnant. So like your progesterone, the value of it doesn't really matter. Like we can tell if you ovulated, that matters. But then it's also like, are we diagnosing PCOS or other like menstrual concerns? So that's where, yes, if we're looking at your ovulation or we're looking to diagnose like a menstrual problem, then that's where we want to look at. But for perimenopause and menopause, it kind of doesn't do much for us. And that, like, unless if you have a hysterectomy or you don't bleed because of an IUD or an ablation, then that, yes, we have to use hormones to tell, like, to give us a judgment call because you aren't cycling, so we don't have anything to feed back on. But me and you could have the exact same symptoms and our estrogen levels would be totally different. Or
Mhm.
we could have the same estrogen levels and our symptoms are totally different. So, like, what your actual estrogen value is kind of doesn't matter because what I'm not treating a number, I'm treating you.
Mhm.
And so, really, it's just taking a good case and figuring, and like I said, in that time, that's when I can figure out, like, oh, you have sleep issues, but it's only the week before your cycle, or it's only 2 days before you bleed. Like that's a pretty obvious, like, ooh, we're creeping into that perimenopause state. But in
Mhm.
a 7 minute appointment, like your that family doctor doesn't have the opportunity to answer those questions unless you blatantly outright have already made that connection. Um, and so I think like I get it. We go for the testing because we want the answer, but a lot of times when we'll come into my office and be like, I just want my hormones checked, and I'll have this whole spiel. And like, I want you to do lab work. I want to know what your iron's at. I want to make sure it's not your thyroid. I want to make sure your cholesterol and your sugars are there. But then when we talk about your hormones, I'll be like, I kind of like it doesn't, I don't need to know that right now. Or also like if you're postmenopausal, they're low.
Mhm.
Like you don't need to spend the money for me to tell you that like your estrogen and your progesterone are not detectable. They're done.
Well, and too, Brittany, like when you talk about that, like um chaos of like the hormones kind of like up and down and not like sometimes I think of, when someone posts a picture on Instagram, like that picture doesn't represent your life. Do you know what I
Mhm.
mean? Like that's a snapshot in time, but that's not a good representation of what's going on. So I think about that sometimes like, well, I don't know when you're getting it tested and like it's going to be different in an hour or
Mhm.
different like in next
I might
week.
like the 2 months down the line that I see you when you had your hormones tested, that's a totally different cycle. Like
Yeah.
maybe you didn't ovulate that cycle, but now you are going to ovulate right now. Or
Mhm.
like it's going to be you're not as strong and your estrogen is higher. And so like honestly, people just want the understanding.
I
People just
know.
want to know what's going on. They want the explanation. And if they don't know how else to get it other than lab testing, because that's what we've always been told. That's how the system works right now. And if they can't find those resources somewhere else or they can't get that education, I get it. But it's unfortunately not going to give most people what they want it to give them.
Well, and that's what I find is like when someone's visibly, and I see this all the time, people coming in and just like kind of like, kind of like commiserating, like I am like struggling so much here. Like I need some answers. Like nothing's the same. I just need help. But I always think like, oh my gosh, this person's gonna be so overwhelmed. If they think they need to get their hormones checked and they wait for a while to go see a naturopath or their family doctor and they walk in and they don't order blood work, like which I get why you don't, but for that person they're going in with an
Devastating.
expectation of how you're going to help them. And that's why I think like resources like us having this conversation, I'm like, I can give you this conversation for free.
Mhm.
Like,
But
take
it's,
the
or
time
like
to
that
listen to
patient
this.
too. I was thinking for like that patient to go in and get labs and then told they're fine, like that's devastating because
That's
now they're
devastating.
lost
Hmm.
because they like don't know what's wrong with them. And the other part too is the like, I will like, I'll take the labs and sometimes they've been quote unquote fine, but they're not optimal. And that can also be like a little bit of a discrepancy and controversial statement, but those are two different states. Like a non-disease state and where you actually feel well can be very different.
Hmm.
And not looking at the hormones, but we're looking at like blood sugar and iron, like those other things, right? But for the woman who like is not feeling well and they finally built up the courage to go talk to their doctor and like they've made the time in their schedule and they've done it and they've gone to the lab, only to be told everything's fine.
Hmm.
Like that's devastating. Like then they're like, well, it is in my head. Like, fine, I'll take the antidepressant. Like, I don't know what to do.
Well, that's why I think it's so important to educate ourselves, like so that when I do walk into an appointment and I'm feeling like overwhelmed and you tell me like you know what, I don't think your money's well spent on this or what have you, then I'm like, okay, I was expecting her to say that. Or do you know what I mean? Like,
Yeah.
because
And
again,
I think it's
otherwise I
just
think, yeah.
giving patients that benefit of the like letting them know the thought process, right? So if you're not going to run something, I try to explain why that is, right? Or what are we looking for here? Because if we test something, it should change how we treat you or it should change how we proceed. We're not just testing for the sake of testing because no one really likes to get their blood work done. Like, let's get
Well,
real.
can you speak to that? And I think like I just want to make obvious what you've already said is that every practitioner is different. You can't expect all NDs to be the same, and you can't expect all physios to be the same. I'll be honest with you, I'm not the type of practitioner that wants to see you every week, but there's some physios that want you to come in every week. And I just have a different style of practice. And I think you'd say the same things. I think a lot of people would say, like, I'm like hemorrhaging money at my naturopath's office for like all these tests all the time. But like, can you speak to that? Because you just contradicted. That sounds like I'm being like controversial here and that I'm like attacking you. But like, because that's what people will say, like people, I think what you're trying to say is that no two practitioners are the same, and you kind of have to do your research too as a consumer of
Totally.
like, who am I going to see? And maybe you want those tests and then you should go see someone that does a lot of
Yeah.
testing.
And that's, I think
But
you like, that'll be my biggest, that's the biggest negative that I'll hear from whether it's like other professionals or other patients. They'll be like, I went in and I just like spent thousands of dollars. And maybe, I don't know what, maybe we would, like maybe together we're working. But the thing is you would understand why. And I
mhm,
think it's you, like you said, I think we need to feel comfortable in advocating for ourselves and screening our practitioners and asking these questions to them, right? And so you need to feel comfortable. If I'm giving you a recommendation, you have to be able to tell me that's not going to work, whether it's financial, whether I just like can't commit to it, because otherwise both of our time is wasted here.
mhm,
And there's like there are some people who will really want to test XYZ after we have this conversation. And I'm like, fine, sure. Like we can if you want, or we can do whatever. But like you run like it's your body, it's your health. And so like I'm not gonna gatekeep anything, but I don't need a lot of the times after this conversation, they're like, great, like I can spend $300 somewhere else. Right now, everything's expensive right now. We don't need like people could use $300 sometimes. But it is like just like screening your practitioner, being able to ask these questions. And I'm not gonna like some my patients do often leave on supplements, but they will understand why they're on it, what the intent behind it is, and how long do we expect for them to be on it or before we're going to see the effect, or what were the other options. Like, for example, if someone's coming in to work with me and they have anything related to their cycle, the birth control pill is always on the table. And they're
mhm.
always flabbergasted that I'm like, you did not come to a naturopath to get a birth control pill. I can guarantee you that. But I want you to know that this is why it might be offered to you and that like this is where it might be given to you in the conventional system. And if you want to, we can. And I'll go through all that like to the spectrum of like, we're gonna just do stress management and sleep support. And depending on the woman in front of me, they might be like, you know what? My life is too chaotic. Let's do the birth control pill. But
Mhm.
like, which is exactly what they would have gotten at their family doctor. But now they actually know all the options and like the pros, cons, everything about it.
Well, and I think like I'm sure your practice is the same in as mine in so many ways. Like I literally say there's a bit of a menu of options here, and healthcare is trial and error. Like I can't promise you anything. Like that's why I think like basically what you're saying is you treat based on symptoms. Like yes, some of the lab findings, but some of it is like you can't just treat a number. You have to treat a symptom. And so
Mhm.
some of it's trial and error. And I want let's try this. Let's see how you feel. You're feeling great. Awesome.
Even when
right?
it comes to the hormones, right? Like our
Yes.
estrogen is available as a gel, as a cream, as a patch. We've got like, and one, the standardizing isn't like the dose isn't the same across, but I could give you a patch and you just like, it doesn't work for you because you just like
Hmm.
don't absorb it or it's not, but like a gel works magically
Hmm.
and
So,
it should work, but
yeah.
it's trial and error and figuring out like what works best for you lifestyle wise, what actually absorbs, what covers your symptoms, like that kind of thing.
So you already mentioned like, yeah, you come to me in your early 40s and you're having some symptoms of chaos. Um, and this person comes in asking for hormones. Like, can we talk a little bit about hormones now? So when would you, so we've talked about how, you're going to look at lots of different things like diet, exercise, sleep management, but like when are you going to be thinking in the back of your head, like, I think this person would benefit from some hormone supplementation?
So if we're gonna follow like the classic picture, I'd say, usually in early perimenopause. So this is when we're talking about like maybe late 30s, early 40s. These women are generally good candidates for either a progesterone or, and let's play like the natural devil's advocate. Sometimes a birth control pill is like what they need in this part, but they're looking for like cycle regularity, general support. But if we're looking at like hormone replacement, progesterone is usually initiated earlier in perimenopause. And then as they get to the mid to late perimenopause transition is where we might start the estrogen conversation. And that's where the cycles start to be farther apart, is usually a sign. And that's where we'll see some of these more obvious ones like the hot flashes, night sweats, palpitations. Even if it just happens like joint pain, but we'll start to see that and the cycles are going farther apart. But usually it's progesterone first and then estrogen closer to. Now, one thing I just want to say here, because I'm still unfortunately hearing it, is you can start hormone replacement therapy before menopause.
Mhm.
There are still some practitioners out there that will say, like, nope, we can't do anything until after menopause. Or I've also heard you can only take the birth control pill in perimenopause, and then at 50, we change you to hormones. The birth control pill is an option, but that is not your only option. And we can start hormone replacement therapy before menopause. And for many things, like for mood, we know that it's actually more beneficial the earlier it's given.
What about, so I have a lot of clients that they're around the age that I'm like they have an IUD or they're on birth control and they don't really know what their true cycle's doing.
Mm-hmm.
At what point, like sometimes I'm confused about, again, as a physio, I don't say like, oh, you must get your IDU out now. Like that's not my business to say. But sometimes when they are, let's say they're coming in with a lot of the joint pain, um, they're starting to get some incontinence, some urgency. And I'm like, and I ask about that, and they're like, well, I don't know because I have an IUD or because
Mm-hmm.
so what do you like? I've heard before that like that you'd want to start seeing what your natural cycle's doing and that maybe taking out an IUD or stopping something like a birth control around that age 50, 52 to see what's going on. Like
So
what
my question that I would ask, like say if you're a patient coming in, I'd be like, well, what are you hoping to gather from that? What would that change? Right? So if we take out your IUD or we stop your birth control pill, assuming that like contraception is not an issue,
Mhm.
but like, what are you hoping to learn here that we couldn't maybe learn in a different way? Or how would that change what we do? So for the patient with the IUD, a lot of women can use an IUD and we can very safely initiate hormone therapy while they still have the IUD in. And so it helps for those women who have a lot of women who have an IUD have a bleeding problem, right? So they have super
Yeah.
heavy bleeding or their periods are like, do you want to take that out and
Mhm.
then just figure out that you still bleed and hemorrhage and like have a massacre once a month just to maybe
Mhm.
decide to put it back in and have like most people don't.
Mhm.
Um, like the standard of care, quote unquote, would be that we would keep it in and then once we would confirm that they're in menopause with an FSH, so this is a case like where we would test, then that's where we'd be like, okay, like we can take it out. We probably don't need it. And
I
we fully
see.
transition to progesterone as uterine protection. That like the IUD can be used for a very short time for uterine protection. So we might not need the oral progesterone, but you can still start that. Now, the birth control one is a very different situation because And I'll say like, so quote unquote standard of care is that they would stay on the birth control pill until the average age of menopause, which is 51, 52. And then that's when they would come off and transition into hormone replacement therapy. So, but your question is that, so for that patient on the birth control pill, if they're now having symptoms of it, that pill isn't right for them anymore. So do they want to stay on the pill? Like, do they like that? We have so many pills at our disposal. So maybe they were on a super low dose estrogen one before, and now that's not a good fit. But if they do want to come off of the pill, like then we look at other, then we can test later or see what that picture is. Coming off the pill is a bit different because it's easier, right? It's not a whole procedure. You don't have to get it put in and out. You can just like stop it for a couple months, see what happens, and then start it again if you choose to. But I think it would really depend on what their goal is.
Okay.
And I will say for both cases, vaginal estrogen is fine.
Totally. Yes.
Vaginal estrogen is like, for the most part, almost always a good idea.
Totally. I feel like like you're not having to, let's say, really advocate for that anymore. Like I find a lot of those people with those symptoms, I'll just send a note to the family doctor and there's like really no hesitation to start
Mhm.
vaginal estrogen anymore. So I'm curious for a lot of people that are going to fit like kind of 40 to 50. Do I have this right that your kind of advice is if you're having some struggles in that transition, whether it be related to kind of, mental health, mood, sleeping, like brain fog's another huge one, maybe some of the heart palpitations. I feel like the body weight composition changes, all of that, you have an option to have some support with that inconsistent time.
Mhm.
It it is not that everybody needs hormones, but it's an option that
Mhm.
you could try. Tell me the downsides because obviously, like without going into a ton of detail, there has been so much bad gossip around hormone therapy. So that's everybody's number one hesitation that I've heard it's bad. And again, we're always learning in healthcare. And essentially, let's just talk a little bit about some of the bad gossip or the bad publicity that hormone therapy's had before. But I guess I'm wanting to get out of this, like, what would be some of the downsides for people starting? Because I think we found that, like, oh shoot, some of those recommendations were not, they shouldn't have been there in the first place. So then
Yeah.
what are the true negative consequences to starting something? Because I'm sure you'll say like, well, depends on what they get out of taking it. It would be the cost if you don't have benefits, and it would be the
Mhm.
the hassle of trying to figure out the right concoction, if you will, for yourself or the
Yeah.
right like dosage. Would you say, will you
Yeah.
speak to all of that I just tried to say?
So one thing that you said like at the beginning that I wanted to was like, I'll so if you think something is off, right? Like we are talking about like when we feel confused, if you think something is just not right, it might not only be your hormones, but it's probably also being impacted by your hormones.
Mm-hmm.
And I think when that gets dismissed is when women don't feel heard. It might fully be your job, right? Like
Mm-hmm.
that might be a huge aspect of it, but your stress resilience and your ability to cope with that has changed because of your hormones. So I would just want to, though we've said that there's like, we can do different other things and there's so many symptoms, just your hormones might not be the only thing, but they're probably playing a role,
Mm-hmm.
especially if you're like late 30s to like mid 50s. Like they're probably playing a role. Now, to go to the hormone question, the like draw. So one of that we're gonna like is huge is that Women's Health Initiative, and it's interesting that you bring this up because I'm actually finding the opposite of because of social media right now. No one cares about the like. Why wouldn't you take hormones? And
Mm-hmm.
I'm the one having that conversation. Like I'm the one being like, I actually like based off XYZ, I do not think this is a good fit for you. I think we should try other options because now everyone's being there's so much people are like, oh, pro hormone, like take it, take it, take it. But there's not a lot of these safety conversations being had. And I'm the one being like, oh, I actually like you went through menopause like 10 years ago and like your cardiovascular was this pretty high. So like, oh, I actually don't know.
Mm-hmm.
And so it's interesting because I feel like I'm having the opposite
Mm-hmm.
conversations now more. But one reason would be obviously, like I kind of touched on there, is like age or time for menopause. So there's this what we call the window of opportunity. So the recommendation is that you initiate hormone therapy within 10 years of menopause and under 60 years old. So you can continue it past the age of 60. There isn't a recommendation of when you come off, but this is more talking about when you start it. And that is because if you start it later, hormone therapy can actually become a risk to your cardiovascular health, as well as the science on dementia right now is we're not as like solid as we are with the cardiovascular on the dementia side. But what we do think is that the later we start it, adding estrogen, or if like the dementia pictures already kind of started, it can actually be like fuel to a fire. So it's not protective. Um, the where we like in the peri side, so if we're looking at the other side of things, if we start hormones too early, you feel like crap. And they're just not like they'll have breast tenderness, they'll have awful PMS, and it just doesn't feel right. Um, and then on the negative standpoint, like one of the biggest things that people are always worried about is that like cancer risk or the cardiovascular risk and all of that. And that is just having like a really good risk assessment and an understanding with your clinician, because everyone's one risk tolerance is different and your risk profile is different too. So some women don't even love like a 2 in 1,000 increase of their breast cancer risk. They're like, nope, that's too much for me. And some women were like, I don't care. Like they understand that there is an increased risk there, or that like because of their family history or whatever, they're like, but I want this because of these benefits. And so it's having that really good risk benefit discussion with your clinicians.
Mhm. What's it's so interesting. And I
It's
think
so
like
interesting too. And then to play like the devil, we don't have this conversation over any other prescription.
I know. And
Like
it's
you
funny
don't have
how
this conversation over a birth control pill. Like there's not podcasts about this like huge conversational birth control pill or like a PPI or like, but like hormone therapy, we have this like massive conversation and like emphasis on. It's just it's very
well,
interesting.
you used the analogy of like everyone used to think it was their thyroid. Like everyone wanted Synthroid to support their thyroid. Why do we think that we don't deserve hormone to support like a deficiency or a change? Like if you are aging, you will not be ovulating as much and you are
Yeah.
not making them. Like it's not, you're just trying to top up to a level that you used to have, right?
And I think that part comes. A lot of women will be like, I want to just do it naturally. Like, why can't I just get? And I'm like, hey, but our expectations of our life are so different than they were 20
I
years ago.
know.
Do you want to live like women did when they were 20 years ago at 55? Probably not.
Mhm. And I
So
think
you
at the
might
end
need
of the
support.
day, like that's kind of like we all get to choose our quality of
Mhm.
life. And that's what I like, everybody gets to decide how they want to live their life. And I think that's where, like, when I talk about some of the symptoms I've had, like, I feel like an acceptance and kind of like this makes sense. And I'm trying to give myself a lot of like compassion, like self compassion. And when I'm getting some of those symptoms, instead of being like, oh my God, I'm going crazy, I'm kind of like, oh, Mel, like, we're kind of in it for the long haul. And like, I try to think of, some of the positives, but I get to decide how I live my life. And that's
Mhm.
where I find that there's more appointments going towards this and trying to advocate. And I truly see it as trial and error. Like I have some of these conversations, like I know I've had some with you before, but also with my family doctor, I think is very open to me coming in and saying, like, I'm reading about this. I feel like I'd like to try this. Do you have any
Mhm.
reason I can't? And I'm okay with trying. Like, I understand I might not like this. I do a lot of that. And I suggest to a lot of my clients, educate yourself so that you go into that appointment with, for example, your family doctor or with Brittany or whoever, so that you
Mhm.
can go in with having a bit of an idea of what you want. Like,
Mhm.
I've educated myself about these things. I think I would like to try hormone therapy, whereas someone else is like, I don't want to start there. Cool.
And I
Go
think
in
I
and
love what
say
you asked
that.
there. Like, is there a reason not to? Right. And
Sure.
so sometimes they might say no, but because you haven't asked that question, they don't say why they're thinking that. And you might be like, oh, that's a very valid reason. Like, thank you.
Yes.
The world is very pro the XYZ right now. So I don't hear that. Um, and one thing that I just want to state is that also in like through this transition, hormone therapy is not the only way
Yeah.
to have good quality of life in the future. Because I'm having a lot of women come in that are feeling like they're, say, like 10 years post menopause and they like feel like they've missed the boat and that
Mm.
they don't have because of the conversations that we're having here. And they're like, now we've come to the determination that it's not a good fit for them. And they're like, well, what am I going to do? Like,
Hmm.
I'm out of it. But like, we can still do so many things to help with your bone health, your cardiovascular risk. Like, we
Hmm.
know like good quality lifestyle stuff that can help.
Hmm.
But like you can choose in the option, but if you hormone therapy does not feel right for you, it doesn't have to be the only way.
Mm-hmm.
especially because right now there is such a pro or like if you don't do it, you're missing out. Um, I just want women to feel like that they're not losing if they choose not to, or if that's not a good option for them.
Mm-hmm. Some of the messages I feel like I'm hoping people take out of this are one that like it's normal for this to be a tough transition. No two people will experience it the same. And like you said, you use the similarity to puberty. Like I don't always remember everything that I went through in puberty, but I have a girl that's going to be going through puberty soon. And I can absolutely imagine that all of us parents will be getting together and kind of being like, oh my God, like she's doing this.
Yeah.
And like but the other daughter is not doing that. Like it's going to be different, but like we are bracing ourselves for this, right? And so I think thinking about that again and just acknowledging and accepting that this is going to be tough. Because I think that's what we do with our kids is we
And
hunker
you
them
give them
out.
space, right? You
We
give them
give them
space for these
space and
emotions and these
acceptance
things because
and
you know. Yeah.
validation. Like, of course you're feeling like this. And I also think like going in with our eyes wide open. So again, I think of some of my friends that are like, no, switch the subject. I'm gonna like send this to them. I'm like, tell me when you listen to this. But then another one I want to ask you about, because I've been trying to tell my clients about this, is that I feel like a lot of people will come out of this quote unquote difficult transition and say, like, I feel amazing. Like, I weathered the storm. I hear a lot of people say, like, best days of my life. And
Yeah.
so, would you say that you hear that too? Like, a lot of people are like, I went through
Well,
puberty.
let's think about like
Yeah.
hormones are the same every day.
Yeah.
Like,
See?
how cruel is that? Like,
Hmm.
there's no more PMS, there's no more fluctuations. Like, once you, like you said, once you weather the storm, it's the same. It's consistent. Like, that's lovely. But
Hmm.
also, like I said earlier, it's this beautiful opportunity. And so, if you take advantage of it, and this is you can't get away with the same shit you got away with in your 20s and 30s. And
Hmm.
so now you have to take care of yourself because otherwise it's going to show up in your sleep or your mood or whatever.
Hmm.
And so this transition will force women to finally take care of themselves or put themselves first. And it also brings to light, oh, I should care about my bone health and my cardiovascular risk and
Hmm.
all of these other things. And so, and that's like women will come with to me for their hormones. And I'm like, hey, well, if you're going to work with me through menopause, we'll work on that. But we're also looking at these things.
Hmm.
Like, I'm sorry, but now we're talking about your bones. Now we're talking about your heart because
Hmm.
this all matters.
Hmm.
And the opportunity and what they take in this chance, now they've made all these changes. And whether it's from like whatever choice they choose for treatment, but they've made like all of that carries on too.
Well, I hope people get some good gems from this. And we talk a little bit about like how people can find you, because I know you do a combination of in-person and virtual
Mhm.
help.
Yeah. So I'm virtually available to anyone within BC. If you're in other parts of Canada, you can always reach out and I can try to connect you with a practitioner if you're interested. I do offer, and I think this is a great thing to take advantage of, especially I think most NDs do it, is like the 15-minute discovery call. So you can like chat, ask your questions. Are we a good fit? Do we vibe? That's important. But yeah, so you can mainly social media is the best place to find me. I think it's like at Dr. Britt Schamerhorn.
I'll
No, we'll
add
take me.
all that in the show
Yeah.
notes. People will have access to all the ways to contact you. Yeah.
Yeah.
Anything else that you feel? I know we could talk about this in different angles of this conversation for days and days, but for the purpose of this discussion, anything else I didn't ask you about that you feel is important to share?
No, I think this was great. And I think if like women can just know that it might be chaos, but there's options. And we educate and learn about what to expect, but know that you deserve to feel good and you can feel well through the transition. And we don't, you said something earlier that just because something's common does not mean it's normal. And so in women's health in general, we need to stop accepting that. Like we can feel good, even if everyone around you is tired and that's what's normal, we can feel better. And like, you have to be the change in your group. Like it sounds like you are to influence everyone around you to be like, you can actually feel better. And so it's chaos. It might not feel great sometimes, but like we can feel better and we can do stuff for it.
Well, and I think you can look at it two ways. Like, oh my God, it sucks to be a woman, like all these things, and what else could be harder? Or look at how complex we are. Like, look at how resilient we are. Like, how, look at how unique we are. Like, that's a different way to look at it, right?